So let's talk about antibiotics for community-acquired pneumonia. So consensus guidelines for the management of community-acquired pneumonia in the global south vary by country, and a significant amount of differences exist. In addition, the research on the treatment of community-acquired pneumonia, specifically in adults, that is originating from the global south is largely lacking. The following recommendations are a combination of guidelines from the Infectious Disease Society of America treatment guidelines for community-acquired pneumonia, published in 2007, as well as the Medicine de Sans Frontières 2016 treatment guideline reference book, my own experience and that of my colleagues. But please do consult your own country's local treatment guidelines for further treatment options which may be more specific to your country. So the regimen I propose is that if the patient is being treated on an outpatient basis, so they have a CURB 65 score of 1 or 0 and sometimes 2, it is appropriate to use either azithromycin alone, 500 milligrams on day 1 and 250 milligrams on day 2 to 5, if this is affordable and available in your country. Another option is to use amoxicillin, 3 grams a day in 3 divided doses, which has great coverage from strep pneumonia, but does not cover atypicals like azithromycin. Or you can use the combination of both. If you suspect the patient has an atypical pneumonia, or maybe they have risk factors for having beta-lactam-resistant pneumococcus, which include everything from immunosuppression to heart disease to dialysis patients to debilitated patients, or patients who have recently taken antibiotics. A third option is to use an oral fluoroquinolone, a respiratory oral fluoroquinolone. This will have great coverage for both strep pneumonia and atypical organisms, but may be more expensive or not available readily in all countries. And the one that is usually most available is levofloxacin. It should be given at 750 milligrams daily. If the patient has been hospitalized, so their CURB 65 scores anywhere from 2 to 3, but is not severely ill, they should receive 1 or 2 days of IV antibiotics. And the intravenous choices include IV ampicillin, 3 to 4 grams daily in 3 or 4 divided doses, IV penicillin, 1 to 5.5 million international units daily, and then you should consider also adding azithromycin if you suspect the patient has an atypical infection based on interstitial pattern of infiltrate on chest x-ray, or if the patient is not improving after 48 hours, as the IV ampicillin and penicillin will have good coverage for strep pneumonia, but poor coverage for atypical organisms like mycoplasma and chlamydia. Now, if the patient is severely ill, in other words, requires the ICU or has a CURB 65 score greater than 3, we recommend you initially give them 1 or 2 days of ceftriaxone or cefotaxime, which is 1 gram IV daily. If there's no improvement after 48 hours with this treatment, IV cloxacillin can be added at 8 grams daily in 3 to 4 divided doses to cover for possible staph aureus infection. In addition, if any of your patients, outpatient, hospitalized, or severely ill, do not improve after receiving appropriate antibiotics for 48 to 72 hours, you should strongly consider tuberculosis as the possible etiology of pneumonia, and if so far you haven't treated for an atypical infection, consider things like mycoplasma and chlamydia and add azithromycin. Improvement criteria for pneumonia typically include reduction or cessation of fever, reduction of respiratory rate, improvement in oxygen saturation, improvement in appetite and activity tolerance. And one last note. If azithromycin is not available in your country, you can also use doxycycline or erythromycin to cover atypical organisms. However, if doxycycline is used, which is usually the most widely available, You must also always use amoxicillin or penicillin or ceftriaxone, as doxycycline has suboptimal coverage for strep pneumonia.